Thank you, Dr. Wijaya for a nice introduction. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. It is an honor for me to share findings and recommendations regarding our study on fluid intake and hydration status among the pilgrims in this prestigious conference. My outline will be the Hajj, the homeostasis of fluid balance, assessing dehydration, and findings and recommendation. So annually, millions of Muslims all over the world gather at Mecca, Saudi Arabia, to carry out religious activities called the Hajj. Indonesia, as the biggest Muslim population country, sends approximately 156,000 pilgrims each year during the Hajj. Of course, the environment in the Saudi Arabia very different from Indonesia. Saudi Arabia has desert climate with extreme ambient temperature and humidity, while Indonesia is a tropical country with moderate temperature and high humidity. You can see here in Saudi Arabia, the ambient temperature may reach 40 to 43 degrees Celsius, while Indonesia is around 30 degrees Celsius. The huge crowds, the extended stay, and the extreme climate, along with the quite strenuous activities, increase the risk of health problems among the pilgrims, from communicable disease such as respiratory tract infection and meningococcal disease to non-communicable disease such as cardiovascular heart disease and environmental heat injury. There is an increased risk for the pilgrims to suffer from dehydration and heat stroke, particularly when the Hajj period takes place during summer, which leads to high morbidity and mortality. The two main causes of death among Indonesian pilgrims were cardiovascular diseases and respiratory diseases. We can see here that the death among Indonesian pilgrims approximately 0.4% in 2015. There is a homeostasis of fluid balance in our body. The fluid input comes from the beverages, the foods, and our own body metabolism, while the urine, the insensible water losses from the skin and the lungs, as well as feces and the sweat production, contribute to our fluid output daily. The balance between the input and the output of fluid every day determine the hydration status, whether it is euhydration, dehydration, or hyperhydration. In order to maintain the fluid balance, one should adapt the fluid intake in accordance to the fluid output every day. For example, in the heavy physical activity, the sweat production may reach up to 5 liters a day. So the person should adapt with by consuming a certain amount that fulfill the output fluid in the day. Besides climate condition as an external factor, other external factors such as access to safe drinking water, as well as internal factors such as age, gender, BMI, comorbidities, functional status, cognitive status, as well as level of education also contribute to the development of dehydration among the pilgrims. We can see that the age, gender, and body mass index influence the hydration status due to the difference in body composition. Like Dr. Fiasri has explained that the increase in BMI contribute to dehydration status in the subject. The presence of comorbidity also increase the risk of dehydration. The age-related decrease in thirst sensation also may prevent the elderly from having sufficient fluid intake. The sensory, the cognitive, and mobility impairment will limit the fluid accessibility. that all increase the risk of dehydration among the pilgrims. When dehydration happens, our body will increase the blood osmolarity and reduce the blood pressure in order to stimulate hypothalamic osmoreceptor, leading to reduced salivation, which manifests as dry mouth, and trigger the sense of thirst. By ingestion of water, it will then cool and moisten the mouth and also rehydrates the blood. There are several common normal body response to dehydration, such as decreased attention span, acute decrease in body weight, dryness in the tongue and the armpit area, increased renal water concentration, increased thirst, and decreased urine flow, as well as increase in heart rate, decreased blood pressure, and increased capillary fill time. And dehydration is very serious problems that can complicate from minor complication such as decreased ability to concentrate, constipation, to fatal complications such as thromboembolism, hypothermia, and ultimately death. How to assess dehydration? There are several methods to assess dehydration. From invasive, expensive, and sophisticated methods such as isotope dilation method, measurement of plasma osmolarity, measurement of blood urea nitrogen to creatinine ratio, and saliva parameters, to non-invasive and maybe less expensive such as measurement of urine osmolarity and bioelectrical impedance analysis, to non-invasive, easy to administer and with quick results such as urine-specific gravity and urine color. In addition to the fact that there is no gold standard to diagnose dehydration, to detect dehydration in the community, especially during pilgrimage, even more difficult. Therefore, detecting dehydration among pilgrims with urine-specific gravity and urine color will be the reasonable option. Urine-specific gravity has good sensitivity and specificity with around 89% sensitivity and 91% specificity. It is as accurate as urine osmolarity measurement with low inter-individual variability, and it is recommended to be used in large population studies. However, the result is affected by the particles in the solution such as glucose and protein. The study on fluid intake and hydration status among the pilgrims is still rare. There is still no data on how much the daily fluid requirement that prevent the pilgrims from dehydration. Therefore, the Indonesian Hydration Working Group, in collaboration with Hajj Health Center, Ministry of Health, Republic of Indonesia, conduct a study on fluid intake and hydration status among the pilgrims in 2015. The objective of this study is to evaluate the hydration status and fluid intake among Indonesian pilgrims, as well as diagnostic accuracy of urine color chart compared to urine-specific gravity. This was a cross-sectional study during pilgrimage in August until September 2015 on apparently healthy Indonesian pilgrims from Banten province whose age above 18 years old. We exclude subjects with hematuria, proteinuria, and or glucosuria. Every subject fulfilled the 3 days fluid intake records form, while the urine color chart and urine-specific gravity were evaluated by the trained Indonesian pilgrim health officer. We define dehydrated state when the colors number of urine color chart more than 3 and the urine-specific gravity more than 1.020. 521 subjects were participated in this study. The subjects were approximately 59% female, only 21% aged 60 years or older, and with median age 50 years old. More than half had low to moderate level of education. These demographic characteristics were similar to the characteristic of Indonesian pilgrims in 2015 as a whole. We can see here that the female proportion is quite similar to our study. Regarding age, the same. We have similarity. Only about 20% is 60 years and older. And also for level of education, low to middle is about 36%. Based on urine-specific gravity and urine color chart, the dehydrated subject were 31% and 35%. While Nurali found that 19.5% dehydrated patients among Indonesian pilgrims who were hospitalized at Hajj health care facility during Hajj in 2014. This study showed that the proportion of dehydrated pilgrims in the community is higher than what was found in the healthcare facility, which makes that we have to undertake serious early intervention in order to prevent from minor to fatal complication of dehydration. We did further data analysis and found that there were no significant difference on hydration status based on USG and UCC between age and sex group. And there were also no significant difference of clinical manifestation representing hydration status among subjects, except for fatigue. But we were not really sure whether the subject's fatigue due to the dehydration or the quite strenuous activities. Sari also found similar result in her study on dehydration among elderly admitted to emergency department at tertiary hospital. We can see here there is no significant difference of clinical manifestation among dehydrated subjects about thirst perception, fatigue, forehead turgor, or mouth mucosa. Among non-dehydrated subjects, the median fluid intake approximately 3.3 liters, which significantly different from their counterpart dehydrated subject whose median intake only in the range of 2.7 until 2.8 liters per day. However, we found no significant difference of fluid intake among subjects based on age and sex group. Compared to urine-specific gravity, urine culture had approximately 59% of sensitivity, 74% of specificity with 51% of positive predictive value and 80% negative predictive value. Baron found linear relationship between urine color, the specific gravity, and osmolality. Urine color chart is a cheap and non-invasive method to assess dehydration, not require technical expertise, and give immediate result. But it is less sensitive, 81%, specificity 97%, and affected by dietary illness as well as medication. In this study, we found low sensitivity with quite high negative predictive value. Therefore, urine color chart may not be reliable to screen dehydration among the pilgrims, but might rule out dehydrated state when the result was normal. Since the fluid intake significantly contributes to the hydration status among the pilgrims, and it is projected that the Hajj period in the next 10 years still will be taken place in summer. So we recommend that the pilgrims should consume at least 3.3 liter water per day to maintain fluid balance. But it should be noted that the fluid intake requirement may increase when the average temperature is higher than the average temperature when this study took place, around 42 degrees with humidity in the range of 24 to 67%. The urine color chart should be given to the pilgrims, and knowledge on urine color chart and how to use urine color should be massively socialized among the pilgrims. The pilgrims should be encouraged to achieve the normal color of the urine color chart. Thank you for your kind attention.